Jessica has no questions. Okay. Yes, Jennifer.
So whatever we went over, basically you're gonna give us like a question, like a scenario question, right?
Well, yeah, maybe something is, like I have a person that had a EDV of 150. I'm going to change numbers so you don't memorize it. He had an end diastolic of 50 and his stroke volume was 60. What was the ejection fraction? Just a simple math thing like that. Simple math thing. All right. Anybody else? A lot of stuff. All right. We lost some people. All right. Okay. Yes, Christine. What's up?
Hi, I'm going over, you posted like a cardiac, like, it's like a study guide, and I'm like going through it. It's like the one with that has all the tables. Is that just helpful information to as we're learning or studying?
The lecture notes?
Yes.
Yeah, that's just a guideline. Yeah.
Okay.
Yeah. You can add stuff. All right, let's continue. We lost some people along the way, but we'll press it out of here. We should be done by 8 o'clock or so. Okay, so we just spent a lot of time on cardiac output, and now, yeah, what Katie just said. Well, you guys should be either, like I said earlier, download the PowerPoints, or if you have a tablet, and just be, putting stars where I said this is going to be on the test type of thing. All right. Okay. So what affects cardiac output? Well, obviously heart rate and stroke volume. And that's why we talked about the endocrine system earlier, and the parasympathetic and sympathetic nervous system earlier on our first day. So yeah, the autonomic, just remember that the sympathetic wants to speed the heart up, the parasympathetic wants to slow it down. And we can do that with epinephrine and norepinephrine, or even our thyroid hormones. The stroke volume is more what we call intrinsic, in terms of what's going on with the heart without involving hormones or neurotransmitters to any great degree. And so your simple little thing is here. Here's my cardiac output. Heart rate, again, depending on whether it's parasympathetic or sympathetic, to speed up and speed down. Very simple. Stroke volume, how much blood was ejected, has a lot to do with how much blood did I start with. Down here where it says EDV, how much did I start with? And that depends on how much blood came back to the heart through the superior and inferior vena cava. And that is based on how did I get the blood back to the heart? And that's the skeletal muscle pump and the respiratory pump. I'll explain that a little bit. There'll be more involved when we actually talk about your blood vessels on the vascular side. During a sympathetic response, you're going to constrict all the veins and push the blood over to the arterial side because I'm going to need it. We also have something we're going to discuss in a little bit called contractility. How strong are those cardiac muscle cells contracting? And that has everything to do with the sympathetic nervous system. All right, so this is kind of just an overview slide. So, stroke volume. We have intrinsic. Remember, intrinsic just means local. What's going on right there? Extrinsic means either nervous or endocrine. All right, and here is a glorious slide. Oh my goodness. Isn't that beautiful? How do you like those colors? Aren't they soothing to the eye? Yeah, it's pretty. You could stare at that slide for God knows how long. Okay. Yes, and this is one of Katie's creations. So you give credit to Deanna. You can do better than green. All right. How would you describe this color? This one right here. Who's my aesthetes? Who's my artistic folks? What color is that? No one? I don't have any artists. Christine goes with teal. Cindy goes with baby green. I've ever heard of baby green.
Looks like mint ice cream.
Mint ice cream. Okay, now we're getting somewhere. Maybe mint ice cream. Beautiful. That's nice. I want a little bit more artistic for this one. What color is this? Come on. No one? So light pastel green. Okay.
Aquamarine.
Aquamarine. Wendy says aquamarine. Okay. All right. That works. I was going to, oh, there we go. Yeah, well, of course, Katie came. Yeah, very good, Samantha Alvarez. Seafoam green. That's what I was looking for. And Katie confirms that since she created it. So seafoam. And let's one more. And the last one. What color is this? Come on, Deanna, we can do better than light blue. Pastel, mint green. I don't think that looks like mint green to me. Sky blue. All right. Anybody else? Okay. I would call it robin's egg blue. Robin egg blue. All right. What's my point here, folks? What's my point? Yeah. Okay. Good. Very good. All right. So, and it's just a nice little logical thing. So, yeah, this is a really important slide. Okay. All right. So, follow the logic here. Increased venous return. How much blood is in the right atria? The blood that came from the superior and inferior vena cava. All right. So, the more blood you have coming back to the heart, the larger your end diastolic volume, the amount of blood in the left ventricle. If you have a lot, the heart is going to stretch. Remember what I said earlier, the heart is very elastic. It's going to stretch. And because of that stretch, it's going to have a stronger contraction. It's the same thing as a rubber band. You know, the farther back you pull it, the more it's going to sting. If you used to do that stuff. That is what's called Frank Starling's law. Know that. So it's a very simple concept. The heart is elastic. The more it stretches, the more it's going to rebound. The more it rebounds, increases that contraction, the more stroke volume. Everybody got it? Very simple. You got to know it. All right? Again, this is very important because if you have a tired heart, your high blood pressure and all kinds of bad things are going on with it, and it just doesn't stretch as much. And if it doesn't stretch as much, you don't have much contraction, you don't have much stroke volume, and it's everything we talked about with ejection fraction, what percent came out. All right? Beautiful. And this is just kind of a slide just showing you the more blood that goes into the ventricles, the more it stretches, and the more blood I can eject out to a degree. All right? And again, you don't have to memorize these numbers, but just showing you what is possible within physiological parameters. All right? And again, this is important because, again, if you have a weak heart and it's beating fast, you're not giving the ventricle enough time to fill with blood. So you don't have a very high EDV, so you don't have very much of a stroke volume. And so once again, it's a vicious circle. You know, I have to pump faster because I'm not pumping as much out, and that's when you go into cardiac failure. All right? And I hope that makes sense. So it's very simple. The longer I keep the ventricle relaxed, the more blood can fill and the more blood I can eject. All right? And that's a very important concept because, again, if I have somebody with a high heart rate at rest, they're not going to have a whole lot of blood in that ventricle, and they're not going to have a big or much of a stroke volume. All right, moving on. Contractility is a little different than Starling's law. Starling was all about how much it stretched. Contractility refers to the strength of the contraction due to the amount of calcium. Remember what I said earlier today. The more calcium I have inside the cell, the more it can bind to troponin, the more it can move tropomyosin out of the way, the more actin myosin bridges I can form, the more power stroke. All right? That's what we mean by contractility, more calcium. Ooh, look at here. How pretty. So here's our famous G protein link receptor. Here we have our norepinephrine. And if you remember on day one, we talked about adrenergic receptors. So beta 1 is the adrenergic receptor on the heart. When norepinephrine binds to it, we have a G protein link sequence that you better know by Monday. And we have our second messenger cyclic AMP. It's going to do a lot of things. I'm going to get more calcium into the cell from the outside. I'm going to get more calcium out of the sarcoplasmic reticulum, so more calcium binding to more troponin, and so on and so forth. That's why we covered that essential concepts, because I told you it comes back. It all comes back. So you have to know that essential concept stuff. All right? So again, it's all about the amount of calcium you have in that cell. It determines how strong the contraction is going to be. All right? And so here's your little flow here. Norepi bind to beta 1 receptors. Cyclic AMP messenger system. It's all about calcium. If you notice, every one of these boxes refers to calcium. All right. Now you don't have to memorize this flow chart. Don't spend your time. Just understand that I need a lot of calcium for a strong contraction, but at the same time, remember, I can only relax my skeletal muscle or cardiac contractile cell by getting the calcium out of there. So I want a bunch of calcium out to bind to troponin, but I also want to get that calcium back in the SR and out of the cell as fast as possible for my relaxation stage. Because again, my heart rate is up. This is epinephrine. This is an exercise. I want a more forceful contraction, but I want it to be of short duration because I'm beating so fast. All right? Beautiful. And again, application. I don't think I mentioned this before, but what if I want to slow? I have a cardiac patient and I'm trying to keep the heart calm. I don't want it to beat faster or harder. So what do I give a person with a cardiac condition? I know the term. Very good, Andrea. Yeah, I give them a beta blocker. What does that mean? Simple. That means I don't let epinephrine and norepinephrine bind to that beta-1 receptor. I block it. I have a drug that says no. And so none of this stuff happens. I don't have a strong contraction and I have a slower heart rate because I block the beta-1 receptor. You need to know that. We talked about cardiac reflexes. We'll talk more about this when we get to the vascular system. But again, I have lots of input to the medulla. And so the medulla controls your heart or influences your heart. And depending on whether I want to speed up or slow down, I have centers in the medulla that can speed up, what we call cardioacceleratory centers, or cardio-inhibitory centers. So I can control the heart through nervous input. And that would be from baroreceptors found in your carotid artery and your aortic arch that are monitoring your blood pressure as well as the amount of oxygen you have. If the pressure is low and the O2 levels are low, I'm going to speed up the heart. And vice versa if it's too high. And again, heart rate. Now remember, when we talk about heart rate, we're talking about the autorhythmic cells being influenced by the medulla. So this is all about speeding things up and slowing things down. So sympathetic, beta-1 receptors, increasing the sodium and calcium in the cells, increasing the rate of depolarization. Parasympathetic, I want to slow down the heart. Muscarinic, who can impress me for a gold star? What receptor is acetylcholine going to bind to slow down the heart? Oh, well, you guys got a lot of studying to do. Yes, Jennifer.
If it's acetylcholine, wouldn't it be a muscarinic receptor?
Well, yeah, but which one? Okay, Deani got it. M2. That might be on your test as well. Okay. Now, here's a summary slide, or almost a summary slide. How does it work? With a sympathetic stimulation, I'm going to open up sodium and calcium channels. I'm going to let sodium and calcium in, so I'm closer to threshold. I don't have very far to go to reach threshold. So we're looking at the bottom one here, sympathetic. All right, so I can speed it up because it doesn't take me very long to get to threshold, because I'm closer to threshold because of all that additional sodium I let in and calcium. With the parasympathetic, I want to get farther away from threshold, so it takes longer to get to. Can anybody remember, how do I get farther away from threshold? This is in your first essential concepts block. How do I get more negative inside? Anybody?
When potassium leaves the cell.
Excellent, Derek. Excellent answer. Very good. How does that happen? I open potassium channels and let potassium leave. Excellent answer. I hope everybody got that. If you have no idea what Derek was talking about, you need to go back and look at the first lecture of this course. So acetylcholine binds to an M2 receptor that consequently opens potassium channels. Potassium leaves, and now I'm less positive, or I should say more negative, farther away from threshold, so it takes longer to get to threshold, slowing down the heart. Beautiful. And this is just a summary slide of everything I just talked about. Everything I just talked about. All right. The last slide is not testable. It's just, this is how a lot of people die. Okay. You have high blood pressure. You have atherosclerosis, meaning you got clogged arteries. So again, they're not as elastic as they should be. The heart's not as elastic as it should be. The heart is working so hard and it just can't deal with it. And this is kind of scary. If you look over here at the x-ray, cardiomegaly, look how big that heart is. That's like 4 times the size it should be. How do I fix this? How do I fix this patient? Very good, Andrea. Yeah, that's the only way is a heart transplant. Are they going to give this person a heart transplant? No. Well, you can always put it depends in there, but probably not, because that's a good answer, Christina. Probably not, because because a big part of this is the blood vessels themselves, which we'll talk about next unit. So putting a new heart in this patient may keep them alive a little bit longer, but it's going to end up in the same the same situation, because again, it's part and parcel to everything else that's wrong. But again, this is just your GWAS stuff. This is, again, we're looking at a person that's probably morbidly obese, has atherosclerosis, has super high blood pressure, maybe a heart attack or two, and the heart is just done. It's like, I can't do this anymore. And it gets damaged, and what they mean by dilated cardiomyopathy, the heart is damaged. And what does any tissue do when it's damaged? Okay, before it dies. Scars, but I'm talking about immediately after it's damaged. What happens when you sprain your ankle? What is your biggest concern? Okay, what am I looking for? Starts with an I. All right, Josh, inflammation. Okay, inflammation. And yes, your heart can get inflamed. And once again, when your heart is inflamed, it's swollen, then we go back to where I wanted to emphasize, this can't happen. If it's swollen, then you're not going to get a whole lot of blood in there because the ventricles are swollen. It's not going to stretch because it's swollen. So the rest of it is just going to reduce stroke volume to the point where, yeah, it's reversible. So the answer is, yeah, heart transplant, maybe if they let them, but typically this is end result. All right. Any questions? All right, now we'll wrap this up by going to your lab handout. Now you're going to go to the one that says online COVID. So it will look like this. Give me a sec. All right. So here's your lab handout. Everybody can see that? And again, this is labeled as the online COVID lab handout for physiology. Now again, if we were in lab, you would get to do a basic EKG, ECG, to each other. It's very simple. It's certainly not as detailed as one with the 12 lead. This one you use a 3 lead, but you would still be able to discern the P, the QRS, and the T wave. All right, so I want you to read through this. There's a couple questions about this on your exam, not in great detail. All right, what I want you to focus on is, oh goodness, all right. So on this one, pay attention. Is everybody paying attention? Hold on. Okay, so there's 2 lab handouts. Whoops. One is the online, and what I want you to do is go to where it says watch this video and watch a basic ECG. Just watch it, all right? Then, where your test questions are going to come from is the other handout. So be careful here. So let me pull this one up. And then you're going to go to lab handouts, and it's going to say EKG Lab Original. Original. Okay? So the online COVID is, I just want you to watch the video. Your test questions will come from the original one. And I'm pulling that up right now real quick, and we'll go over a couple of the questions on this lab. And 1 second. So once again, this is the EKG original. And again, I want you to cursor down, and again, don't spend too much time looking over this because we didn't do it in lab. But like I said, it's just a basic 3-lead EKG. What you need to focus on, really, don't worry about the duration of the P, don't worry about any of that stuff. What I want you to study and focus on are the questions. All right. So be able to label a EKG. So atrial depolarization, you would say simply what wave? Okay, I know you just got this today, so. All right, thank you, Christine. The P wave, very good. All right. So you'll go through and answer these. This would be a test question right here. Okay. Here is one that includes what you were taught in essential concepts. So we talk about the autorhythmic cells. All right. This is where you're going to talk to me about calcium channels, T channels, L channels, the IF channels, and what goes in and how does it repolarize. And then here is the heart block stuff that I covered just a little bit earlier. So if I have it, let's see what we know. Myocardial infarction damages the SA node. SA node is out. Who's controlling the atria? Somebody. The AV node, very good. The AV node, all right? The AV node is still in the atrium, so yes. And what would be controlling the ventricles? Almost a trick question. Very good, Cindy, the AV node again, all right? Because everything else is fine as far as my conduction pathway. B, complete heart block. All right, so the SA node is okay, but the SA node cannot communicate with the AV node. So they're not communicating. So who's controlling the atrium? Very good, Christine. Jennifer, who's controlling the ventricles? And we just went over this a little bit earlier. No communication between the SA node and the AV node. SA is controlling the atrium. Who's controlling the ventricles? Come on, folks. Why would you say the Purkinje fiber? What's wrong with the AV node? Is it broke? No, the AV node is just fine. Yeah, but like I said, it's not being controlled by the SA node. It's working on its own. So the SA controls the atrium and the AV controls the ventricles. All right. And then I covered this just a little bit, ectopic focus. So now I got a little spot and I drew a little starburst. It's in the left ventricle and it's depolarizing at 120 beats per minute, which I just covered. All right. So again, the SA node is still going to control the atrium. All right. There's actually insulation between the SA and the the atrium and the ventricles. So even though I got this renegade little portion of the heart that's at 120, it's going to control the ventricles, like I said earlier. And the atrium are going to be controlled by the SA. And of course, this is a no-win situation because now the ventricles are contracting way faster than the atria can provide blood, and that's your sudden death heart attack. What caused the heart block? Well, it just told you right up here. You know, you can have a myocardial infarction, any kind of heart damage. So that's a no-brainer, okay? And remember, when you have a heart block, the SA node is not communicating with the AV or the Purkinjes, so you have different rates of contraction between the atrium and the ventricle, okay? And then who can answer this question real quick? And then we're done. Anyone?
Is it the B?
I'm looking at C now. In the heart block, the atrial rate is normal, high, or low? Why would it be high? You can't put two answers. All right, so Josh and Christine, pick one, and Cindy, pick one. All right. It's normal. Okay, the SA is fine. It's normal. Can I end? All right, hold on. Okay. Well, that's too big. Okay. Oh my God, you can't be kidding me. All right. So the atria are normal. Okay. The SA is normal. Remember, a block means the SA is not communicating with the AV or the Purkinje fibers. That's all it means. So if I have a heart block, the SA is controlling the atria, it's normal. But the ventricular rate is what? Okay. Good. Excellent. Yeah. Because the ventricles are either being controlled by the AV, which is low, or the Purkinje, which is even lower. So, okay. All right. So there'll be a couple test questions from these questions right here. And again, if I asked you to explain how you would identify a heart block on an EKG, you would say what? I have extra whats? Looking at an EKG, I know I have a heart block when I have extra whats.
The P?
Very good. P waves. Extra P waves. Very good. Beautiful. Any questions? Okay.
The B, I'm sorry, Professor, I'm sorry.
Mm-hmm.
The B says, what is happening during a complete heart block?
Mm-hmm.
Could I say heart failure?
You're going to say that the SA node is not communicating with the AV node in the Purkinje fibers. All right? It goes back to, it goes back to, let me go back to my little artsy drawing here. Way back. Where is it? Now, let me pull this up real quick. So refresh everybody, because I know this is your first opportunity to see this stuff. Okay, so remember, during a heart block, I have a block, and think of it literally like a roadblock, all right? You got a big giant fence in front of you or something. So this SA node, it's doing its work, but it can't communicate, it can't control the AV node. So they are independent now. They are independent, all right? And I can have this heart block anywhere. Whoops, I'm going to do that. So if the SA and the AV node has a block in between it, then they're not communicating. The SA node controls the atrium. The AV node is going to control the rest of the ventricles. Okay? It's that simple. If I have a block here, now the SA node and the AV node can communicate just fine, but the AV node can't communicate with the Purkinje fibers. So the roadblock is here. So now, in this situation, my SA node controls the atria. The AV node can't communicate, so who's controlling the ventricles? Anyone? Very good, Samantha. The Purkinje fibers. The Purkinje fibers. Okay. Does everybody get that, or are we still having some confusion? Yeah, it's not easy. And again, I hate that because surprise, surprise, Purkinje is the name of a person that identified him. So that's the name of a person. But what are you going to do? And I hope this comes across to everybody. All right. So this is something else I would have done in class. So Christine is going to be the SA node. Andy is going to be the AV node. And Joshua is going to be the Purkinje fibers. Everybody with me? So if I have a perfectly healthy heart, Christine is going to generate the action potentials and tell Andy, okay, go with my rate. Andy's going to go, okay, I'll go with Joshua. Yeah, very good. I'm glad you said that, Andy, because this is what I'm going to do. All right. So everything's fine. Everybody's following Christine's rate because we're all communicating. Now, Christine generates action potentials, but Andy went to get a cup of coffee. She's out of the picture. So Christine is still working the SA node. Who's controlling the Purkinje fibers? Josh, very good, very good. All right. Now Andy comes back in the loop, but Christine and Andy aren't talking to each other. They got in a fight. So they refuse to talk to each other. So Christine is doing her SA node thing. Andy, the AV, is not listening to Christine. So who's controlling the ventricles? Very good. Very good. All right. No, not Josh. Andy's fine. She just doesn't like Christine anymore.
Oh, I need to go get coffee, so I didn't know.
Okay, so Andy's back in the picture, but her and Christine don't want to speak to each other. So Andy's going to do her own thing with the rest of the conduction pathway. So Andy will control Josh, and everything's fine. I don't know if that worked to help you guys, but again, it's all about who's communicating with who, and that's how that works. Any other questions, folks?
Yes, Professor. Can you talk a little bit more about the ectopic focus, since we are still here?
But again, the ectopic focus, and again, I just put this, I could have put this anywhere I wanted, all right? But it's an area where we have autorhythmic cells that aren't behaving like they're supposed to. They're not following the rules. Remember what the rule is. SA controls the AV controls the bundle branches and Purkinje fibers. But here's a renegade group of cells that said, nope, we're going to do our own thing. And we're going to generate action potentials faster than the SA node. All right? So now the SA node is doing its thing with the atria, but now my renegade cells are controlling the ventricles. And if they're generating action potentials at like the lab handout says at 120, well, the ventricles have to follow that ectopic focus. So now the ventricles are going to beat at 120 per minute, where the SA is at 70 to 80. This is not a livable situation. Because as I said earlier, if these ventricles are beating really fast, there's not enough time to get blood in them. Does that make sense? And ectopic just means
Yeah, thank you.
it's not. It just means it's not like Katie said. It's not where it's supposed to be. That ectopic focus isn't supposed to be doing there. It's not supposed to be doing that. All right. Yeah, like Katie. Yeah, so you can have
Thank you,
ectopic. Yeah, ectopic pregnancy just means the embryo's not in the uterus. It's somewhere else where it shouldn't be. Okay, so that's a very generic term. So the whole point of this is a couple rules. Remember, whoever's generating action potentials the fastest wins. So if I'm beating 120 at the ectopic, it doesn't matter what the AV and the SA node are doing. The ventricles are going to follow the faster action potential rate. And this person would die, okay? This would be your ventricular tachycardia, like we showed in the first one right here. So this is what it would look like, tachycardia. And you start with a this is just GWiz. You start with a tachycardia. The ventricles are beating too fast, not enough blood going into the ventricles, so not enough blood going to the actual heart itself through the coronary arteries. And so you end up with the fibrillation. You have this, and then you die. Any other questions? And again, the one thing is testable, so the moral of the story is take care of your heart. And remember down here, for the heart block, you see those extra P's. Extra P's. All right. No questions, you guys. It looks like you have a lot of study to do. I'm thinking. All right. Katie, the test day, well, again, the test is Monday, and I'm going to open, what time did I say I was going to open it up? I have it written down somewhere.
At
10
10,
a.m.
and then you can close at 11:59.
Okay, somebody had that memorized. 10 to 11:59. And remember, you're going to have two tests. You're going to have the lecture exam, and you're going to have the lab practical. It doesn't matter which one you do first. I don't care. All right?
Now, my question here is, are we just allowing that broad window just for exam one, because that's usually the one that the students bomb? And then for the rest of the semester, it's going to be a sort of 5:30 p.m. to 7:30 p.m. window? As
Well,
people sort of hit their stride, they get the rhythm of it?
we'll see. We'll see how they do.
Okay.
We'll see. All right? And I would discourage you.
Deanna's like, shut up, Katie. Shut up.
Well, you just probably scared the daylights out of him when you said most of them bombed the first test. Okay?
Yeah, seriously. Don't freak out if you bomb the first test. You're not alone.
But that's not going to happen because everybody's going to spend the whole weekend studying. All right? And again, you can take either one first. It doesn't matter. But each of them is timed. And one more time, once you open it up, there's no return. You got to keep going. And the clock will run out at the designated time. And that's it. You don't get
I didn't catch the time frame. I think it's 70 for the exam and 40 for the practical. Can I leave it at
I
that?
think that's correct. Yeah. Well, if you need to use the restroom, you would do that before you started the exam. Okay? If you have to use the restroom for some reason, then you just better do it really quickly, because it cannot stop the clock. All right? So either you go before or you hold it, or if you're a guy, you can just have a little bucket next to you. Whatever, but there's no stopping it. Yeah, okay. And here's your gee whiz. Happy Father's Day. Don't bomb the test. Very good. Very good. Okay, folks. Good session. Again, remember, you can always text me if you have a panic attack and you need to be talked down, or you have a question, then you'll be fine. Yes, Derek?
Professor, do the questions have same weighting? Like if question 1 is 2 marks, question 3, or different weightings?
They're different. They're different. Some questions will be longer than the others. And you can see that. You should be able to see that, how much the question is worth. So there will be questions that are worth 5 points, and some that will be worth 2 or 3 or 4.
Okay.
And that's probably one thing I would recommend you do, is to take a couple minutes and look through all the questions before you start answering them. So you can see, that's what I would do. I would sit there and go through them rather quickly and say, yeah, I can do that one. Yeah, I can do that. Yeah, oh, I don't know about that one. I'll wait to the end. That type of thing. But take a good look at the whole test before you just jump right in. Right?
Thank you. That's why I asked.
Mhm. Remember, folks, there are 10 metric conversion questions. So please go through the metric slide. You have to know your prefixes. In fact, you know what? I'm not even, you know what? I think I just feel compelled to go with this. So we're going to spend a couple extra minutes here on this. Okay, so this was supposed to be kind of just a tutorial for yourselves. What you guys really need to do is memorize the prefixes right here. Okay, those are the ones that you will use in medicine for the most part. All right, there are a lot more prefixes, but those are in physics and chemistry. For medicine and most biology, those are the ones you need to know, and you need to know what they mean. All right. This is a very important slide, especially the exponential values here. You absolutely have to know them to do the 10 conversion questions. Also, I want to emphasize, you see what's in green? That's what you need to know for the test. You need to be able to convert metrics to English, the green ones, back and forth. You can use a calculator. All right. So this is for units of length. I want you to know the relationship between a centimeter and an inch. For volume, liter to quart. Notice how they're very, very, very close, almost the same. Very close. For, again, I just want you to know that one. Anyway, and then for mass, I want you to know the relationship between a pound and a kilogram. And people always get these confused. A kilogram is much heavier. It's twice as heavy as a pound. So try to remember this on the test, all right? If I ask you what your weight is in kilograms, it's going to be less than what you weigh in pounds. It's kind of a joke. You sound lighter if you use your weight in kilos. So if you weigh 150 pounds, you're going to weigh about 70 kilos. All right, so it's always less with kilos. Don't forget that. Some of you are going to get it backwards. And if I say, how much do you weigh in pounds? And you're going to say 300 kilos, which would make you morbidly obese. That'd be about 500 pounds. So don't get them backwards. Kilo, heavy. You always sound like you weigh less in kilos. The other little thing I want you to know is this little conversion, because the metric system is a brilliant system. It was designed by a bunch of smart people. So everything is related. And water was one of the standard things they used. So it's not a coincidence that 1 milliliter of water weighs 1 kilogram, 1 gram, 1 gram. That's not a coincidence, all right? And in fact, I'm going to write this in here. 1 milliliter, oops, 1 milliliter is equal to, sorry folks, equal to 1 cubic centimeter. So in the old hospital movies, you may hear somebody say, hey, give them 10 cc's of this or 20 cc's of that. Well, that cc stood for cubic centimeter, which think of a small sugar cube, which is equal to 1 milliliter. You won't find a syringe nowadays that says cc on it anymore. It will say milliliters, but they're the same thing. So I may ask you a question. Let's see who can get this on the test. All right. How much does 750 milliliters of water weigh? Anyone? How much does it weigh? Very good. Very good. 750 grams. How many kilograms is that? out. $750 grams. Okay, very good, Natalia. 0.75, 0.75. Okay, and that's why you need to know the prefixes. And on top of that, if you haven't went over Katie's tutorial, and that's Katie's voice on the tutorial, you're going to be kind of hurting on this test. So once again, let me go back here. And more than likely, what I'll probably do is, if you guys don't do well in the metric, we'll have another lecture for the next test involving how to do these metric conversions. But I'm pulling up this right here just for a second. I'm not going to go through the whole thing. But this is one of Katie's masterful little tutorials that if you go through it, you should be in great shape. All right. One second. Okay, everybody see this? Okay. All right, and so again, this is interactive to a degree. So the only way I can show this to you is if I go into slideshow mode. I'm not going to go through the whole thing. Can everybody still see it? I need a verbal confirmation.
Yes.
Yeah, okay. Once I go into the slideshow, I can't see you guys.
Let's practice solving a metric problem using dimensional analysis. We're going to be converting 5 milligrams per deciliter to grams per liter. Here are the conversion factors you'll be using. Notice that this problem involves a concentration, as in a solute dissolved in a solvent to form a solution.
Professor, it's not doing anything except showing the main page.
Yeah.
It's not?
No, yeah.
Sorry, just a dimensional analysis tutorial.
5 milligrams over 1 deciliter.
Yeah.
Now I see it.
Oh, yeah, but again, only way I could show you how that works is in slideshow mode, which doesn't work for you guys. So what you'll do is you'll download it, put it in slideshow mode, and work it through. But like I said, Katie did a great job of simplifying this, but you have to know these equivalencies, which is those prefixes. You just have to know them. But if you go through her presentation, and she has some practice problems you can do at the end. Hold on, I can pull that up, I'm pretty sure. So if you go through the whole thing, down here she has some practice problems, okay, that you can work. Now remember, one last thing. I cannot emphasize this enough on my exams. Now Katie's makes you work really hard, and some of these are kind of crazy, but understand why we use prefixes. We use prefixes because we're usually dealing with very large numbers or very small numbers. Jennifer said she did them all. Fantastic. Then you're in great shape. Like I said, we use prefixes when we're dealing with really large numbers or very small numbers, and we don't want to have to do that. I don't want to put a bunch of zeros in there, and so I use a prefix to get rid of zeros. Pay attention to what I'm saying. So on your exam, I'm just going to out and out say, on your exam, when you're doing these conversions, and you've already put in 3 zeros or more, you did it wrong. You went backwards or something, all right? Your answer should be smaller than what I gave you as a conversion. Does everybody get that? Yes, Jennifer. So for instance, I'll do the very first one. It looks like somebody's already done these. So 350,000 micrometers or microns, as we say. We don't want to use big numbers like that. So I can convert it to centimeters. You need to know the prefixes. You need to know micro is 10 to the 6th, so 6 places. And centimeter is 10 to the 2nd, 2 places. So the difference between 6 and 2 is what? What's that? 4. So all you have to do is simply move the decimal 1, 2, 3, 4. And so your answer is going to be 35. Very good, Christine. All right. That's it. But again, if you go the wrong way and you're telling me that the answer here is I hope after the first 2 zeros, you realize your answer is, or either way, your answer should never have more zeros than what you started with, okay? It should have less. That's the whole point of the prefixes. And some of you are not listening, you're going to do that, and you're going to give me a bunch of extra zeros. But again, if you can just remember, if you write more than 2 or 3 zeros, then your answer is wrong. You went the wrong direction. All right? But go through the dimensional analysis and do the practice problems. Okay? Any questions? All right. Lots to do this weekend. Lots to do this weekend for you guys. Yes, Christine.
Can we use scratch paper as well?
Oh, of course. Sure. Sure. Definitely. Anything else, folks? Okay. All right. And I will post the videos because I know that was a lot of stuff thrown at you for you to review for this exam. Okay. And all right. Okay. Have a good day or evening. Study, study, study. And good luck. No class on Monday. Your Monday is just your test. That's it. All right. Your brain hurts. Well, take a couple aspirin, take a nap, and then get back to studying. Okay. Remember, the best way to study is in chunks. 30 minutes studying, take 20 minutes off, go back for 30 minutes, 20 minutes. That's the best way to study versus trying to cram it all in at the last minute. So just take 30-minute study sessions and then lots of breaks. Okay. Goodbye, everyone.